Hey everyone, welcome back to part 7 of our 15-part IPDRG masterclass right here on Decode Healthcare with Harshal. Today's explainer tackles something that is the absolute bedrock of medical coding, those crucial ICD-10-CM inpatient coding conventions. Honestly, these are the foundational rules that will completely make or break your coding accuracy.
Before we dive in, if you are enjoying this lesson, please like, share, and subscribe to this channel. And share it with friends for this free course on Decode Healthcare with Harshal. Let's help coders everywhere level up their skills.
All right, so here is our agenda for today's lesson. We're going to quickly recap why conventions matter, break down excludes 1 versus excludes 2, dive into etiology and manifestation rules, tackle code also and placeholder X, and finally wrap up with a summary and next steps.
Okay, let's jump right into Section 1, a quick recap and exactly why these conventions matter so much.
You can think of conventions kind of like the traffic signs and structural rules built directly into your ICD-10-CM tabular list and alphabetic index. And following these rules, well, it isn't optional. It's precisely what ensures compliant code selection and proper sequencing. And why does that matter? Because correct sequencing drives that IPDRG assignment. Plus, capturing the appropriate CC or MCC status means your facility actually gets properly reimbursed for the true severity of the patient's illness. Basically, ignoring these conventions is pretty much an open invitation for an audit failure, and nobody wants that.
Moving right along to Section 2, excludes 1 versus excludes 2.
So this right here is a massive trap for new inpatient coders. The absolute crucial point is understanding the difference between the pure not coded here rule of excludes 1 and the not included here but can coexist rule of excludes 2. Excludes 1 literally means these two conditions are mutually exclusive. You just cannot have both at the same time, or the codes mathematically contradict each other. But excludes 2, that just means the condition you are looking for isn't included in this specific code. However, if the patient actually happens to have both conditions, you can absolutely go ahead and report them together.
To put this into practice, let's think about diabetes. Under excludes 1, a patient cannot have type 1 and type 2 diabetes simultaneously. Code E10 completely excludes E11. It just makes clinical sense. But now think about excludes 2. Essential hypertension, which is code I10, excludes secondary hypertension. But a patient might actually suffer from essential hypertension and also have secondary hypertension caused by some totally different disease. If it's documented by the provider, they can absolutely coexist on the exact same claim.
Now, I do need to mention a rare excludes 1 exception you absolutely have to know. Conditions can actually be coded together if, and only if, their etiologies, meaning their underlying root causes, are proven to be completely different and unrelated. For example, hyponatremia and SIADH usually exclude each other under excludes 1, so normally you would only code the SIADH. But if a physician explicitly documents that the hyponatremia is caused by something totally unrelated to the SIADH, well, you actually have a clinical basis to code both.
All right, let's get into Section 3. Etiology and manifestation rules.
In the medical world, the etiology is the underlying cause, and the manifestation is the resulting condition. And let me tell you, this relationship dictates a massive portion of your inpatient sequencing rules. The code first mandate means that the systemic disease or that underlying infection literally has to take the primary sequencing spot. Whenever you see a manifestation code, the ones that often have in-diseases classified elsewhere in their title, it can never, ever be your principal diagnosis. You have to look for that code first note and sequence the underlying root cause in the number 1 position.
Let's think about how this plays out in a real-world scenario. Say you are dealing with sepsis due to pneumonia. You have to sequence the underlying infection first. The sepsis rule in the official guidelines tells us that if sepsis is present on admission and is the primary reason for admission, that systemic infection, the etiology, gets sequenced as your principal diagnosis. No exceptions.
On the flip side, we have the use additional code note. You'll find this hanging out at the etiology code, and it's basically instructing you to add a secondary code to fully capture the manifestation or maybe the infectious agent, like severe sepsis organ dysfunction. Basically, if you have an etiology that causes a cascade of issues in the body, this note is your giant red flag reminding you that one code just isn't enough to tell the whole story. You need those secondary codes to reflect the true severity of the illness, which, as we know, directly impacts your CC and MCC capture.
Okay, moving on to Section 4, code also and placeholder X.
These final two conventions are just absolutely crucial for code completeness and getting your structural formatting right. The code also note ensures that both the etiology and the manifestation are captured. Now, it does leave the specific sequencing order up to the official guidelines, but it's essentially saying, hey, don't forget, these two conditions go hand in hand. Depending on the specific circumstances of the admission, you'll have to dive into the guidelines to figure out which one is actually the principal diagnosis.
So, this actually raises a really interesting mechanical question. What happens when a code mathematically needs a required 7th character extension, but the code itself currently only has 5 characters? Remember, ICD-10-CM allows up to 7 characters. For things like injuries, poisonings, and external causes, you almost always need a 7th character, like A for an initial encounter or D for a subsequent one. But what do we do if the base code only naturally has 5 characters?
Well, this is exactly where the placeholder X comes to the rescue. It acts like a bridge, preserving the alphanumeric structure so that your 7th character can sit exactly in the required position. You literally just insert an X right into the 6th character slot, and sometimes even the 5th, just so that 7th character extension drops into the perfect structural spot. It's honestly a brilliant little piece of coding architecture, and it's what prevents your entire claim from failing validation.
And that brings us to Section 5, our summary and next steps.
Let's really cement these rules, guys, because they are going to define your accuracy as an inpatient coder. Mastering these specific notes guarantees correct principal diagnosis selection, appropriate CC and MCC capture, and clean, compliant claims. So, as a quick recap, excludes 1 shuts the door on combining codes. They're mutually exclusive. Excludes 2 leaves the door open. They can coexist. Code first and use additional code dictate that eternal dance between cause and effect. And of course, your placeholder X is the glue that holds short codes together.
Coming up in our next explainer, Part 8, we're going to take these exact etiology and manifestation rules and apply them directly to the complex world of sepsis sequencing. Sepsis, severe sepsis, and septic shock. It's a heavy topic and a lesson you absolutely won't want to miss.
If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on decoding healthcare with Harshal. And before we sign off, I'll leave you with this final thought. Just imagine how many millions of dollars are lost in hospital revenue simply because a coder didn't notice a code-first instruction hidden away in the tabular list. It's kind of mind-blowing when you think about it. Keep practicing your conventions, stay sharp, and I will see you in Part 8.